Good evening. I'm John Scahill, and I'm Biological Secretary and Vice President of the Royal Society. And this evening, we are celebrating the award of the Royal Society GlaxoSmithKline Prize to Andrew Hattersley. The prize is awarded biannually and has been awarded since 1980 for original contributions to medical and veterinary sciences during the last 10 years. The prize itself is a gold medal, a commemorative scroll, and a gift. And I'll be presenting these, all being well, at the end of the lecture. The prize this year is awarded to Andrew Hattersley, who is the Gillings Chair of Precision Medicine and Professor of Molecular Medicine at the University of Exeter Medical School. And it's awarded for his genetic and physiological studies of patients with common subtypes of monogenic diabetes, the results of which have revolutionized their treatment. And it's my pleasure to invite Andrew to give his lecture from base change to better care in diabetes. Andrew.
Thank you very much, John, and thank you all for coming. It's lovely to see so many friends in the audience. What I want to do today is to tell some stories about how we have moved from understanding genetics into changing clinical care, and to try and talk something about what we've done in the past, but also where we're trying to go in the future. And what I'm talking about is diabetes. And I really see myself as a diabetes doctor who does science rather than a scientist who occasionally does a diabetes clinic. And so I apologize to the scientists in the audience for the quality of the science I will be presenting, and I apologize to the doctors in the audience for the quality of the medicine that I will be presenting, because if you do both, you don't do either well. But diabetes is a very common condition. Over 400 million people in the world have diabetes. And the reason it matters is because it makes people die earlier and it makes them ill. It's the commonest cause of blindness in working people. It's the commonest cause of renal failure in this country. It's a major cause of amputation, heart attack, and stroke. It accounts for more than 10% of spending in the NHS in the UK. And if you can treat it correctly, you can reduce those complications. And for that reason, diabetes is a specialty which is all about treatment. Not so much about diagnosis, but let's get on with treatment and let's reduce complications. And for those of you who are not diabetes doctors, I'd now like to summarize 5 years of specialist training in diabetes. I'd repeat, specialist training. This half of the slide shows that 5 years. This is how you treat diabetes if you're a clinician. You assess how high the blood glucose is, and that decides what treatment you should use. If it's normal, you don't need to give anything. If it starts to go up a bit, then you would advise diet and exercise. If it goes up a lot, then you recommend tablets. If they don't fail, you add another tablet, and then you add another tablet, and finally, when those don't work, you give insulin. So it's a scheme which is based on severity. The idea is that we are treating how high the blood glucose is, rather than treating the cause. And really, it's not that revolutionary idea to think that we tailor the treatment to the cause rather than severity. So it matters why your blood sugar is high rather than how severe it is. And really, the whole idea of precision medicine is exactly that tailoring of medical treatment to the individual characteristics of the patient. What I want to do is to talk to you about this concept in diabetes, the idea of precision diabetes, but specifically tailoring diabetic treatment to the individual characteristics of the patient's cause of their diabetes. And what I want to do is to use genetic information to try and understand the cause. Now, we know diabetes often runs in families. If your parent or your sibling has it, it's much more likely that you will get it, but it's not guaranteed, because for the common types of type 1 and type 2 diabetes, there is just a genetic susceptibility. There's not a genetic cause. But what I'm going to talk about, at least in the first part of this, is a rarer situation where there is monogenic diabetes. A change in a single gene is enough for you to get diabetes. And that's a remarkable situation, because what it means is one of your 3 million bases is changed, and just that one change is enough to end up with you having a condition called diabetes and having a high blood sugar. And when you've got that situation, you then are able to have a diagnostic test for that thing, because you can look at the gene where the change is and say, well, if I find that, then this is that type of genetic diabetes. And then what I can start to do is to say, I've made a diagnosis. What are the clinical features like of that? What's the underlying pathophysiology? And as we've said, what really matters is treatment. You're going to have to go back before 10 years to understand this. And this was the second family I met when I started doing my research with Robert Turner in Oxford. And I'd been given some advice by some very wise people, John Todd, Sir John Bell, and Sir David Weatherall, who said, if you go looking for genes, I recommend you look at genetic types of diabetes. That was the only advice I've ever had from 3 members of the Royal Society. I haven't changed since then. I've stuck with what they told me. The basic principle being, if you want to find genetic diabetes, go to it where it runs in a family. And there's a particular type of monogenic diabetes, or clinical subtype, known as maturity onset diabetes of the young. And this comes from the old days when there was maturity onset and juvenile onset diabetes. And I think if you'd been at this wedding, you might have thought something was going on. Bride was diagnosed at 13, her mother at 17, her grandmother at 23. The bride's mother's cousin was diagnosed at 12, and the 2 bridesmaids, although neither of them was diabetic when this picture was taken, by the time they were 9, they both got diabetes. And in fact, one of the bridesmaids has gone on, become a mother, and she too has a child who was diagnosed at 10 at King's College Hospital recently. And it was a clinical observation by Robert Tattersall that recognised that there was this familial form of diabetes that was coming on young. But the other thing he noticed was that although they were treated with insulin, they didn't need to be. One of the patients said to him, I often have a 2-month holiday from my insulin. Now, if you have type 1 diabetes, you don't have a 2-month holiday. By day 4, you're in hospital. So that meant they weren't insulin dependent. And so this was going to be due to a single gene passing down through the family and resulting in diabetes. So if you want to go looking for genes to find diabetes, there are 2 ways. You'll notice the big genetic studies being used at the moment involve around 100,000 people. So I had 2 choices: study 100,000 people, or go to one wedding and take a few blood samples and find a gene that way. So I chose the easy option. I chose going after monogenic diabetes and doing it with a few isolated families. And because it was relatively easy to find genes, very rapidly we turned a clinical entity defined by clinical criteria into underlying genetic causes. And this was work with major work being done by Graham Bell in Chicago. We're able to break it down and say these are the major genetic subgroups. Now, for most clinicians, that was really a backward step, because what we'd done is we'd taken something they understood and turned it into names we didn't understand. Things like hepatic nuclear factor 1 alpha are difficult to remember. Much easier to remember MODY, and you didn't have to remember lots of different names. But what I'd like to show you is why it mattered that we broke it down into the different causes by explaining to you about some of the different causes that we found. Around the time these genes were being found was when I was first moved to Exeter, initially as an NHS consultant, and I was extremely lucky with the people that were there when I arrived, because the most critical person has been now Professor Sian Ellard, who as there wasn't a lab in the hospital, set one up. So we set up the first genetic lab. We were joined, our first PhD student was Tim Frayling, who now leads the polygenic work in Exeter, and by Maggie Shepherd, who was our nurse, was a diabetes nurse, who has then educated both the UK and the world about what we found in this area. And the great news is that we're still all there, and we're still taking the basic principle that we started at the beginning, which is that it shouldn't be research for clinical care and clinical care. It should be research and clinical care in the same laboratory. And we've continued to do that even as things have got much bigger than they were at the beginning. So this is an example, and this is Liam. And I met Liam because I was looking after his mother. His mother was in my clinic. She'd had gestational diabetes, diabetes in pregnancy, and she'd gone on and was thought to have type 2 diabetes. And she came into my clinic very upset. And she said, my son Liam has just been diagnosed with type 1 diabetes. Now, it turned out what happened was Mum had tested his blood sugar and found it was 10 and had rushed him off to the hospital worried that he had diabetes. They checked it, they checked a fasting blood sugar, and it was raised. It was 6.2, whilst a normal blood sugar in a child would be about 4. So they worried this was the early stages of type 1 diabetes and put him on insulin. But what we were able to say was that this might be a familial monogenic form of diabetes, and the specific type is known as a glucokinase mutation. Now, glucokinase is a very interesting physiology because this is the pancreatic beta cell. And there's basically, this bit over here senses the glucose, and this bit out here secretes insulin. And all the rest in the middle is the machinery that results in that glucose value being translated into the right amount of insulin. Glucokinase sits here. Glucokinase regulates the blood glucose at what level it is. So it's the pancreatic glucose sensor, and it sets the level of blood glucose that you respond to. And this was where Liam had a mutation, and about 1 in 1,000 of the population have a mutation in this. So it's actually a relatively common condition. And the reason it's not known about that much is because what we find is this very unusual pattern where the blood sugar from the day you are born is slightly raised. But instead of deteriorating, it just stays slightly raised, just above the normal level. So this is a condition which, what you get called by doctors depends on when you're diagnosed. So the mother had been diagnosed in pregnancy, and she was said to have gestational diabetes. Liam was diagnosed as a child, so he was said to have pediatric incidental high blood sugar or type 1 or early type 1 diabetes, and other people could be determined as having type 2 diabetes. But the crucial thing is that this is a regulated blood glucose, the same as my blood sugar is without diabetes. And because it's regulated, my body does everything to keep my blood glucose at that level. And what that means is if you give these people treatment, it has no effect at all. You can give them insulin, you can give them tablets, but the blood sugar stays at exactly the same level. We've spent a lot of time trying to stop people taking these tablets and found their blood sugar remains at the same high level because they're regulated there. The other thing we found is that it doesn't result in complications. It doesn't result in problems having a slightly raised blood glucose all your life. And so really we've got 2 possibilities for Liam. One is that he has no treatment and no follow-up, and the measure of how good his blood glucose control is HbA1c is 6.5%. The other world that we rescued him from was being diagnosed with type 1 diabetes, put on an insulin pump these days because you go on it early to try and stop things deteriorating, going to 3 monthly clinics and having exactly the same level of HbA1c. So this is actually the kind of patient we need to discover in order to rescue from doctors rather than because it's a fancy thing. And so this is a situation where there are people who you would find it hard to believe have been on insulin for 18 years by the time we make the diagnosis and take them off it. So it can have a really big impact. This is a different situation. This is Peter, and Peter was from Liverpool. At the age of 13, he had a very high blood glucose. This is nothing like glucokinase. This is enough glucose to give you symptoms, to make you thirsty and lose weight. And he was a slim person, and the immediate feeling was, this is type 1 diabetes. And that was reinforced because his dad had a high blood sugar, very high blood sugar, and he was on insulin and thought to have type 1 diabetes. But then the question was, well, was this really type 1 diabetes? And the reason that came up was when you looked at the rest of his family, then there's Peter and his dad, but we then see that Peter's dad's sister also was thought to have type 1 diabetes. Peter's brother thought to have type 2 diabetes, and his paternal grandmother thought to have type 2 diabetes. So this was a family with a whole group of people thought to having type 1 and type 2 diabetes. But they didn't. They had a particular type of MODY. They had HNF1 alpha MODY, the commonest type that there is, and that's the same as the wedding picture photograph. These do need treatment. If they don't have treatment, they will get severe complications. Again, this is the kind of chance finding. Sometimes finding the cause, immediately you understand how you should treat them. With HNF1 alpha, we really didn't understand the biology, and actually 20 years on, we still don't understand it very well. But we were able to make clinical observations. And this is Peter from my clinic, and at the age of 36, he'd been diagnosed at 25. He came into my clinic, and like many people in their mid-30s, he started to worry about his weight. He read the insert on his tablet, which said because he was on a sulfonylurea, it made him at greater risk of weight gain. So I knew that metformin was better for weight and as good for blood glucose in people with type 2 diabetes, so I swapped him between the two tablets. What I hadn't expected to happen was when I swapped him for his blood glucose to deteriorate. So this year his blood sugars are doubling. He's going up to a very dangerous level very rapidly. And what we found was that as soon as we swapped him back to the first tablet, the sulfonylurea, his blood sugar shot down 5 times greater than we would have expected it to. And so what that meant was these patients were sensitive to this particular type of tablet. We wrote papers about it. It didn't change clinical practice at all. Everyone says if you want to change clinical practice, you've got to do a trial. And Ewan Pearson, who was the clinical research fellow, is a very determined man, and he got the money from the Wellcome Trust, and with that money, he was able to do the only randomized trial, which shows that the etiology of the diabetes alters the response. And what you can see here is that the sulfonylurea, the gliclazide, is 4 times better than it is in type 2 diabetes. And actually, it is so good that actually you can replace insulin with it. And that's exactly what happened here to Peter, that he came off his insulin and went on to half a tablet of sulfonylurea, and other members of the family all managed to transfer, improve their blood glucose control, come off insulin, and go onto a tablet. And so by making the observation in one person, that then has been able to be rolled out worldwide. And so what you've done is you've taken a clinical group, used genetics to define all the different subgroups, and what you've shown is that matters because they need different treatment. So the glucokinase don't need treatment at all. The transcription factors need low-dose sulfonylureas. So that looks like a great idea, but this is only 10 years ago. Dan was diagnosed at 16. Now, at that time, he was working on his A-levels because he wanted to become a vet. And suddenly, he was found to have diabetes and was diagnosed with type 1 diabetes, put on 4 injections a day, and had lots of problems with hypoglycemia, his blood sugar going too low as a result of the insulin. There were multiple other family members. This, wherever it's filled in, showed that they had diabetes in the family. They went to the doctors taking a picture of the family tree and said, "We think this is genetic." And the answer they were given is, "We'll never take you off insulin, so what's the point?" And so this is 10 years after the science has been found that you found the gene, 10 years after you've done it. And I think the crucial thing this shows is that you've got to disseminate your results. And really that's what we've been doing since that time in this area. Because once we found him, and in fact he found us through the internet, came directly to us, he came off his insulin, half a tablet, he's now qualified, he then got all straight A's at his A-levels, went to Bristol Vet School and all the rest, and he's working as an agricultural vet, which is what he thought he'd never be able to do because of his problems with his diabetes. So it's really worth making these diagnoses, and you think, well, this should be pretty easy. It's about 3% of people diagnosed under 30. It's about 40,000 people in the UK. We've got all the technology sorted for making genetics. Exeter provides the NHS screening for the whole country. It's accessible. We've got web forms. And there are very clear treatment recommendations. So you think this science should come into clinical practice straight away. But there is a problem here. Although it's 3% have it, that means 97% don't. Which means if you say it's not MODY, you're still right 97% of the time. And the other problem was that the doctors just weren't used to the idea of a genetic diagnosis. That's not something diabetes do, is diagnosis. We do treatment. And more than 95% were diagnosed as type 1 or type 2, and it took 12 years on average for patients to get the right diagnosis. So what that meant was we had to do education as well as other things. And so one of the things Maggie Shepherd did was to make local experts to take diabetes nurses and instruct them in genetics and make them the regional genetic expert for education, for identifying patients and following up family members. And that scheme has been so successful, it's now been running for the last 12 years, that's been taken up by Health Education England about the way of bringing in the 100,000 genomes. We put up a website and we started to create all sorts of diagnosis and treatment guidelines. We always make things as much for patients. We find the people that are the most motivated to find out about this are the patients. And so we make everything accessible to patients and respond to any queries from them as well. So there is another reason it's difficult. And one of the reasons is this shows the different clinical criteria that you might use. You might use treatment, or whether the parent has diabetes, how old they're diagnosed, the HbA1c, the blood glucose control, or the BMI. So you could use those things to try and tell if it's genetic, if it is one of these types. And the difficulty is that if you use cutoffs, which is what doctors typically use, so something like it's present in the parents and you're diagnosed under 25, you miss people and also you misdiagnose other people. And so what you need to do is to combine the probability of your individual of what is their treatment, what is their parental diabetes, what is their age of diagnosis, their HbA1c, and their BMI, and apply those combined together. And that's exactly what Bev Shields did and created a probability calculator. And what she has done is to put that onto the web. And so for any doctor, you can just put the clinical characteristics in, and it can tell you how likely you are to have neonatal diabetes. It gives us a probability result. We generally recommend at about a 1 in 4 chance that people get tested. But in the end, that decision is based on the probability. Because it's not everybody had access to the internet all the time when they saw patients, Bev has gone on and made that an app, the Diabetes Diagnostics app, and you can all download that either on Android or an Apple phone. And I think the crucial thing is this is actually adding everything together. And you then say, well, how does that do against the clinical expert? And I was somebody who'd had 20 years of working in monogenic diabetes when this came out. So what I did was I went head to head. They gave us cases and they put them into the machine. The probability calculator beat me hands down, which is good because before that I was getting a lot of emails, but now they know they don't need to do that. They can just go to the calculator. So this approach has led to a massive uptake. In 1996, 20 years ago, there were 47 patients with a molecular genetic diagnosis of MODY. There are now 4,621. And that number is going on increasing. And the patients that are being diagnosed, more than 50% are changing treatment on diagnosis. And actually what's happened is this has spread worldwide. There isn't a civilized country that doesn't offer genetic testing for MODY. Now, second chapter. And this gentleman here is Jan Bruning, a paediatrician in Rotterdam. One of the nicest people you can meet. Paediatricians are lovely people anyway. I think they need to be to cope with sick children. And I met him by complete chance. I sat down at a diabetes meeting in Mexico, which to be honest was not great. So I wasn't rushing through my breakfast, and we just got chatting. And he said, do you know there are people that get diabetes so young it can't be type 1 diabetes? And he said, it's got to be genetic, but I can't get hold of any geneticists to find the genes. And I said, well, I'm a geneticist. We could find the genes, but we haven't got any details of the patients. And he said, well, why don't we set up a dating agency where we make sure that the patients meet the geneticists, and we set up the ISPAD Rare Diabetes Collection. There was no money in it. It was just an email that he sent out. And what happened is, really overnight, we had 31 patients who were born with diabetes. And that really was the beginning of a whole new era. We moved from the family testing into testing children born with diabetes. And this is the kind of patient. This is Lily, and she was desperately ill at the age of 3 months. She had ketoacidosis, which is when the diabetes is so severe that you're getting decompensation and it's life-threatening. Her blood sugar was 54, whilst a normal child's blood sugar would be 4 or 5. And she was diagnosed as type 1 diabetes and went straight onto insulin. And that was reasonable because she was producing no insulin. And she had all the problems that people have when they produce no insulin, which is the blood sugar is very, very variable. And that was the real problem. The parents were getting up 2 or 3 times in the night to check her blood sugars. But despite that, she had severe hypos, resulting in seizures during the night. And they became major fundraisers for the JDRF for type 1 diabetes. Unfortunately, they were raising money for the wrong people because she didn't have type 1 diabetes. And what we were able to say is this is not type 1 diabetes because it's diagnosed before 6 months. Type 1 diabetes is an autoimmune condition. You need to have enough time to destroy your islets. You don't have enough time before 6 months. And what we're able to show is that the test for type 1 diabetes, the genetic susceptibility, wasn't present between 0 and 6 months. So now we're able to say that people diagnosed before 6 months have something called neonatal diabetes. And the reason that mattered all changed in 2004. And that was because Anna Gloin, working as a postdoc in Sean Ellard's lab, came to join us and started to work on these samples of patients with neonatal diabetes. And in those days, it was a case of just candidate genes, of guessing what gene you thought it was. And it was the science that was already happened before, quite a lot of it, or almost all of it, due to Dame Fran Ashcroft in the potassium channel, that meant she chose the very first gene that she would test would be this part of the potassium channel sitting in the middle of the beta cell. And what she did was to find mutations, and it was actually a spontaneous mutation, so not present in the parents, but present in the child. And working with Fran Ashcroft, she then took the mutation and she showed that it didn't respond to ATP. Here's the normal: in the presence of ATP, this channel closes. But that doesn't happen when there's a mutation. And what that means is that the pancreas can see glucose, it's got the ability to make insulin, but nothing comes out. Now, there was a real chance here because maybe they could respond to sulfonylureas. And the reason they might respond to sulfonylureas is if you look carefully in this picture here, you see this channel can be closed by sulfonylurea tablets, typically a treatment used in type 2 diabetes. But we were very lucky because although that was a theoretical possibility, what made it a reality was that this patient was in our very first collection. So this gentleman was diagnosed at 3 months. He was then 46 when we did the study, and he was in rural Brazil. And there were enormous problems getting hold of insulin in that area, and it was very expensive. And the parents said, isn't there a cheaper alternative? So the pediatrician put them on a new drug which had just come out of the dye industry called sulfonylureas. And the amazing thing was that he did fine on it. And when we saw him 46 years later, he was still on tablets. He was still And he was the only person on tablets. He had the best blood sugar control of anyone. In fact, he'd gone on and become a lawyer. And one thing lawyers do wherever you are in the world is have enough money. And so what that meant was when his children were then diagnosed in the first 3 months of life, he could afford the insulin, which they went on. So this was the question, who was on the right treatment? Was it the dad, who actually seemed to be making his own insulin, or was it the children who were on insulin who appeared to have none? And the other thing was, could these people that were on insulin actually come off it? That was obviously now a really good possibility, but the problem was, how are you going to test it? There were no protocols written. We didn't have no idea whether they would work or not. And so what you had to do is you just have to try it. And in fact, it was tried in about 5 families around the world pretty well simultaneously, and I would never like to say who was first. But what we were doing was talking to clinicians everywhere and reporting the experience. This is definitely the best documented one. This is from Norway, and this is a patient of Paul Nolstad who had also worked with us on the genetics. And what you see in this picture is, in blue is the blood sugars, and in yellow here is the dose of insulin every day. So as a good scientist, originally he did nothing, just observing the blood sugars. And then this is the tablets, the sulfonylureas, and very gradually, every 3 days, the dose went up. And the amazing thing was that after 1 month, the dose of insulin had halved, but the blood sugars, if anything, were better. And then what happened was that they carried on with the sulfonylureas, and this child who had been insulin dependent, who would have died in the absence of insulin, now had stopped insulin completely and had better blood glucoses than they had previous to that. And the difficulty is, again, it's about trying to convince doctors. The problem for them was this was just a single case report. Were we really sure this person made no insulin before or not? And so what we thought we'd do is we'd do a trial. We'll have some people on insulin and some people on tablets. The trouble was, when we tried to recruit to it, what happened was all the parents said, no, we've done the insulin bit first. We're going to we don't go into a trial going on that. We just want to go onto the tablets. So we did the next best thing, which was a consecutive series, and we took 50 patients. And what we found was that 90% of them could stop their insulin. But what was important was not that they stopped their insulin, but that the blood sugar improved in every single case. And it was not just lower, it was lower without going too low. And what you see here is the fluctuating blood glucose on an insulin pump in an 11-month-old. And here, once they go on tablets, the blood sugar not only comes down, but it actually becomes regulated by their food. And so what this did was transform things. And suddenly for children, they were saying, they've had the first ever sleepover. It's the first time they've played in the football team. And actually, what it meant to them was absolutely enormous. Would that effect wear off? This is the 5-year data. We're now working with the colleagues internationally that we worked with in Norway and Italy and France. 10-year follow-up, it's still maintained. There is no sign that this wears off. So really what's happened is this has come into clinical practice phenomenally quickly. Within 2 years, there was a guidance because there was a very clear guideline, which was if you're under 6 months, you need to be tested for this. There was a clear diagnostic procedure to check the gene, and there was a better treatment. And this is something you don't need to publicize. This just spread. And because there are experts in childhood diabetes around the country, as soon as they knew, and what we said was, well, there's a bit of a problem. What about the cost? What about the places in the world where there isn't a lab? And at this point, we had a patent on the gene because that's what you're encouraged to do by a university. And so we actually took the decision to drop the patent and to make it free. And with the help of the Wellcome Trust, who paid for all that testing, we've managed to offer free testing for anybody under 6 months. And what that has meant is that it's come in throughout the world. We're now up to around 1,700 patients from 87 different countries. And some of the impact of this is most dramatic in the third world countries where they really can't afford the insulin. Places like Vietnam, the state will pay for it until you're 6, and then you have to pay for it yourself. If you're found to have neonatal diabetes, it makes a dramatic difference. But there's another side to this, which is the science. Because if you have all the people that are born with diabetes, you find the 50% that have a potassium channel thing and they can come off it. But you can also start looking for new genes and new causes of beta cell development, beta cell function, or beta cell destruction that can present with diabetes very early. And so there'll be another talk which will talk about what we've been able to find about the beta cell from this knowledge. But it's been a case of confirming some genes that were known about, but also finding new genes that were never suspected from the studies done in mice. Okay, so that's nice, but it's pretty rare. And that's where I've been. I've spent my life there and really have decided in the last 5 years we need to turn ourselves to look at the more common forms of type 1 and type 2 diabetes and really ask the question, can we take the principles that we've had of defining subgroups, can we actually use that to help in type 1 and type 2 diabetes? The first thing is to take that question of is it type 1 or is it type 2 diabetes? Now these clearly have a different cause. Type 1 diabetes is autoimmune, a destruction by the immune system of the beta cells that result in total insulin deficiency, and that means you need insulin. Type 2 diabetes is not autoimmune, and it's not absolute insulin deficiency, it's reduced in the amount of insulin you make and how well it works. And that has a different level of treatment because you don't get complete insulin deficiency. If you get the classification right, we've got some very clear guidance. There are nice guidance for type 1, there are nice guidance for type 2 diabetes, they are very well done, and they're very clear. The problem is there is no nice guidance for is it type 1 or type 2. You might think, well, it's pretty easy, isn't it? You don't have a problem. I'd like to introduce you to a patient who's not known to me, but this is from the Diabetes UK website. Some of you may recognise Teresa, but she's gone public about it, so I'm reporting things that she has reported to the press. 2012, around the time of the Olympics, she had a chest infection, which she was concerned was going to go to bronchitis. She'd also been losing weight, but she attributed that to the stress of the Olympics. It actually turned out in retrospect that she was passing large volumes of urine and drinking more, but she hadn't really noticed it. Her GP very astutely measured a blood glucose, which came back extremely high. And that made the diagnosis, diabetes, and the symptoms fitted with that perfectly. She was 56 at the time, so she was diagnosed with type 2 diabetes. She went on diet and exercise initially. There was no response. The blood glucoses continued to rise. She continued to lose weight. She continued to be unwell. So, following our guidance, he then went on to tablets. After trying metformin, then went on to a second tablet, so increased the dose, increased the number of tablets. There was still no response. And finally, at that point, there was a kind of light bulb moment of, was this type 2 diabetes or was this type 1? And it was reclassified as type 1. She started insulin. She's now on 4 times a day insulin, which has been extremely successful. She is the only prime minister in the world ever to be a head of state who has diabetes, has type 1 diabetes. And she's managing that extremely well. But to be honest, if you can make a mistake with the head of state, that shows that we're really not very good at diagnosing type 1 diabetes. But I do feel for the poor GP, because actually the only guidance that is published suggests using an age of 35 as the principal cutoff. And so there really is not a lot else. There isn't any guidance as to what he should have done. And he's not the only person who gets it wrong. About 7 to 14% of those diagnosed between 30 and 60, the initial diagnosis is wrong. And we found, obviously with Theresa May, she ended up on the right treatment ultimately, and it was just delayed a bit. But if it had been diagnosed wrong the other way and she had type 2 diabetes but was initially thought to have type 1, she would have been on insulin unnecessarily. And we found that 56% of people that went onto insulin straight away with thought to have type 1 diabetes actually had type 2 diabetes. So this is a place where people are making mistakes. So diagnosis matters, not just in these rare subtypes, but in the biggest decision of all, is it type 1 or type 2? But now there's a real question, well, how common is type 1 diabetes over the age of 30? That seems a fundamental question you should be able to answer. But there's a real problem here because we haven't got any definition, any gold standard. Clinical features don't work well on their own. Treatment, we're seeing doctors are getting it wrong, so you can't use treatment to say whether it's type 1 or not. Antibodies are not measured routinely, and even if they are, there are false positives and false negatives. So how about genetics? Can genetics help in this situation? Well, what we've said was this is a genetic predisposition rather than a genetic cause. And it's possible to measure all the variation, all the common variation, and take the 30 that make you most likely to get type 1 diabetes and create a risk score which gives you a value that says how genetically susceptible you are. You can then measure that in a bunch of people with definite type 1 and a bunch of people with definite type 2. And what you can see is, not surprising, that score is higher in the type 1 patients than it is in the type 2 patients that look exactly the same as the normal population. What we felt was that within a population, people that were this low were, if they got diabetes, were most likely to have type 2 diabetes. So we could use this susceptibility score almost in the reverse as a diagnostic test for not type 1. And the next question was to say, well, can we measure the excess of diabetes that occurs in people that are genetically susceptible to type 1 diabetes? So this is a new method developed by Mike Whedon and Richard Oram in Exeter. And it's an interesting idea, and it only works because we've now got Biobank. Biobank is the most wonderful treasure in the research world that we have, which is freely available to everybody, every academic institution, every industry. As long as you get ethical approval, you can go ahead and do it. And the crucial thing is these are volunteers, 500,000 people who agree that their medical records will be allowed and that they will use DNA. And it suddenly lets you ask different questions than you ever asked before. So what we did was we took 120,000 people who had genetic things, and we divided the population into the half that were genetically not susceptible. And we said, well, if they got diabetes, because they're not susceptible, it will be type 2 diabetes. We then said, well, the other half of the population, if they get diabetes, it could be type 1, but they still got the same risk as anybody else of having type 2 diabetes. So we knew how many people were in this half, and we knew how many people were in that half, and then we took that away from that to find the excess. And we said, so this is the excess that you get of diabetes when they have a genetic susceptibility. So it's using the genetics to define a group of people with type 1 diabetes. And that lets you answer the question, well, what age are they diagnosed? And this is the remarkable data, because if you read Wikipedia or any other source of great knowledge, they say type 1 diabetes is a cause of diabetes, predominantly affects children and young adults. What you can see is it is the major cause of diabetes in children and young adults. So under the age of 30, almost all diabetes is type 1. But what you can also see is that, in fact, the prevalence of type 1 diabetes as you come over 30 and 60, there's the same number of cases after 30 as there are before. But the reason it's difficult is because there's this massive amount of type 2 diabetes that is really making it difficult. So Theresa May's poor GP had a 2.5% chance that it was type 1 and a 97.5% chance it was type 2. But what we can then do is we can go on and look at the clinical characteristics of these people, so we can go back to give more clues. And what we can say is that the people who have type 1 diabetes in this age group tend to be slimmer. You can see the BMI of 26. Interesting, like Theresa May, they usually end up insulin by a year, and everybody in the study that was in this group that we called type 1 were all on insulin ultimately, in contrast to 16% of the other group. And interestingly, 12%, so that's 1 in 8 of them, was admitted to hospital with diabetic ketoacidosis. So that is with a crisis. And that was despite, and half of them were thought to have type 2 diabetes in this group. That was their clinical diagnosis. And so really what we want to do is to try and use these characteristics. And I think you can say, well, can we do this? Can we help Theresa May's GP next time? Can we make something a bit more helpful? And I think really what you want to try and do is to put together one of the crucial things, which you came from the MODY calculator, is don't have cutoffs. Don't try and say over the age of 35, over the age of 50. Put in the data and create a probability. And don't just use age of diagnosis, use age and BMI. And then add to that autoantibodies, add to that this genetic risk score. And what Richard Oram did was to be able to do all those things and add them on a group of 220 patients who were kind of in-betweeny. What he showed was that anything on its own doesn't do that well. What you're looking for is the perfect test that you see here where it goes up and across. And this is kind of 98% accurate. And so what happens is if you combine all the different factors, it works brilliantly at diagnosing them. And you could say, well, that's a bit expensive, isn't it? It's probably going to cost in the region of £40 to do all of that. But then you would be accurate, and it's a lifetime disease. And people wouldn't go on the wrong therapy. People wouldn't be misdiagnosed. We'd never dream in cancer of not making an accurate diagnosis. So why are we happy in diabetes not to be accurate? And I think certainly what you could say is there are some patients who clinically you should do this in, and others you may not. And again, the ultimate answer won't be that doctors need to do some fancy calculation. It will come down to an app, and we plan to add this, at least the clinical characteristics, immediately to the Diagnostic Diabetes app. So just finally, the last brief bit. What about tailoring treatment in type 2 diabetes? Anthony and Beryl are very different. Apart from obviously their gender, their different shapes, their different ages, they've got different durations of diabetes, they've got the same level of blood sugar. They've got 2 higher blood sugar having been on metformin, and that means they need some more treatment. But actually the underlying pathophysiology is very different in them. For Anthony, it's predominantly that he's not making enough insulin, whilst for Beryl, the main problem is insulin resistance. The insulin's not working well enough. But what drug are we going to give them? What you'd anticipate is that we would start to tailor their treatment towards them. What does NICE guidance come up with? It produces 4 possible drugs that they should go on, with really no preference as to which they should go for, except for avoiding side effects. But none of them say, do any of these differences matter? Which is a remarkable thing to have. So as a diabetologist, I'm unable to tell you half the patients with type 2 diabetes are obese, half are non-obese. I don't know which drugs, I'd never been taught which drugs worked better. And when we actually went to the literature, there wasn't any data on that. And so if people did know it, it wasn't published. So what do you do when you've got a difficult problem? We were really lucky. The Medical Research Council encouraged us to create an academic industry consortium. And what we really did was to choose people we had who were happy to think differently. And people from industry have contributed that enormously. Because what we wanted to do is to start asking a question not about the whole population, but about discrete groups of the population. The first thing we thought is this isn't going to come rushing in with molecular genetics. It's not going to work on a molecular genetic, high fancy approach that's being used in cancer extremely successful. So let's just start with the basics. Let's start with clinical characteristics. And what we did here was to go to CPRD and to look at, this is GP records, and just ask a simple question, well, does age of diagnosis alter which treatment you do best on? So on these graphs that I'm showing, if you down here you get a better response and up there it's a worse response, and these are 5 different drugs. So what you can see here is all of these drugs are better when the age of diagnosis is higher. So the older you are with diabetes, interestingly, the better you respond. But that doesn't help us choose between our 2 patients at different ages, because all of them are better if you're diagnosed older. So there's no differential response. What about if you're obese? And now it's getting more interesting, because most of these drugs are worse when you're obese compared to not obese. but one of them, thiazolidinediones, actually results in a markedly better response. Why don't we make the question even simpler? What about the simplest test of all, the presence of a Y chromosome, gender? And what we see here is that for sulfonylureas, females have a worse response, while for thiazolidinediones, females have a better response. So you're starting to think we could start to split the population up quite easily here. So that was the next step. Let's split them up into non-obese and obese, male and female. And what you can see here is that the response that you see is dramatically better in the obese females, the thiazolidinediones, compared to the sulfonylureas. But it's completely the opposite way around in the non-obese male, compared where the sulfonylureas in blue are better. But you have to be very careful using your original data set. In fact, everybody would know you can't do that, so you have to replicate it. There's another problem, which is that doctors will put different people on different tablets, so there might be all sorts of bias there. The only way to sort this out is by randomization. So what you could do is do a trial where you randomize them, but the other alternative is to go to some nice, kind people who've done a trial and ask them to give you the data. And so that's exactly what we did. And this is the data from GSK, from the ADOPT trial, and this is in the Clinical Trial Data Transparency Portal. This is allowing people to analyze the data from clinical trials. And what you can see now, those obese females, indeed they do thiazolidinediones even when they're randomly allocated, and they do it for the whole 5 years of follow-up. And in contrast, the non-obese males do exactly the same for the sulfonylureas. We've been able to do that for not only the glycemic response, but also the side effects, which differ markedly between these different groups. So, in conclusion, precision diabetes is a reality, and it's a reality now, that if you can find the cause, it can really improve the patient's treatment. We've seen that very clearly in monogenic diabetes in both MODY and Neonatal. But really the exciting thing is that these massive new data sets and the tools are allowing the possibility of precision diabetes in defining type 1 and subdividing type 2. But it may be that actually bringing this into clinical practice is far more difficult than actually the science to define the differences in the groups. Just leads me to thank all of this work is presented from colleagues in Exeter. The same 4 friends that were present 20 years ago are still there. We've found lots of other people along the way. We've got superb people internationally who we've worked with, and particularly to thank Thran Ashcroft for her amazing work on the potassium channel in neonatal diabetes. But there are a few other people as well. There's some supporters. We've had fantastic support from backers, Diabetes UK in the early days, and Wellcome Trust and NIHR in particular. But then there are other supporters. 2 people on the left there, John Took and Angela Shaw. When I arrived in Exeter, they basically have looked after me and protected me. I felt a bit like an American footballer running over the line, and they've been out there blocking all the things that were going to stop our science, and I'm eternally grateful for that. There's some other great supporters, Susan and my family, my parents and my poor children who've had to cope up with me falling in love too much with my science, but it's very nice that they're all here today. And just finally to thank the patients, because we couldn't have done any of it without them. Thank you.
Fantastic. Any questions? Yes.
Yeah, thank you very much. It's a fascinating talk. Hi, thank you very much. Fascinating talk. I was just wondering, when you referred to the MODY calculator for predicting MODY, how applicable would that be for some of the other ethnic groups or geographical regions where the propensity for obesity or adolescent diabetes is also very high?
Yeah, it's a very good question. And in fact, it's a question that's being asked directly by Shivani Misra, who works at Imperial at the moment, who's collecting that group to specifically develop it. It's got a problem, and the problem is you're trying to pick out the MODYs from the background. The MODYs seem to be about the same in a South Asian or a high prevalence population, but the difference is the amount of type 2s there are there. And so what you find, if you apply the same criteria, you will get a lot more false positives. So at the moment, we think you probably, if you put the BMI in and you take 3 to 5 points off the BMI, it makes it more realistic as a kind of idea. But we're trying to develop that until we've actually got data on that. At the moment, it's just a health warning. But we have published that data. It's just come out in Diabetologia.
So you mentioned that you were developing some applications and putting them in the App Store. How do you kind of get them up higher? Because there's so many apps out now. Don't they get drowned out by all the noise apps that promise miracles but deliver nothing?
We're very naive in this area. I mean, it's interesting because what's happened is this is predominantly for doctors, because for yourself, once you've done it once for yourself, you don't need to do it again. And it's available on the web, so you probably don't want to clutter your phone. But for doctors, and we actually, new media is working. Things like Twitter and personal recommendation has been a great help. And actually, it's downloaded by over 6,000 people already, and most of those will be doctors. And actually, people are now using it a great deal. So I think it is difficult, and it's one of the new challenges. You can't go back to the old ideas of media has moved on, and so I think we have to move with it and learn how to do it. And I think we need help with that, because we're not experts. Thank you.
Well, the first thing I have to say is I have to pay you a visit, really. And the second is, what is do you think is the cause for people developing type 1 diabetes later on in life?
Yeah, I'm glad GSK are here for you to put that question, because suddenly you've got a Prime Minister who has a condition where the evidence base is phenomenally poor. The evidence base for type 1 diabetes is excellent, and there's lots of studies going on in that area. And one of the problems has been, the reason there's not a lot of research done on it was the difficulty in diagnosing it. You can see how Teresa, how would you know that she had type 1? So once you improve the diagnosis, you start to be able to study it more. And that's one of the things that we're doing. I'm sure it's destruction of the beta cells and still autoimmune, so it's still the same process, but how does it differ? And if it's a bit slower, could you intervene more, or is it harder to intervene on? And actually, it's one of the things that we are talking with industry partners about, trying to understand this, because I think it's really important, because it is different. What happens is, because all we've learnt is about children, that we kind of expect people to go completely absent of insulin very rapidly. But as Theresa May showed, it can take months before it goes completely.
Could infections be a part of it?
Yeah, the whole cause of autoimmunity is probably a lecture on itself, and you should ask somebody else to give it. It may be infections. It's actually going up, and it may be the opposite. It may be the lack of infections. It may be what's called the hygiene hypothesis.
So you showed that there's a small percentage of genes which seem to be involved in the development of the pancreas that's implicated probably in neonatal diabetes. Are there treatments for those kinds of diabetes?
That's the real well, as you know, that's really, for so many genetic disorders, are developmental disorders. And if we can improve that, we don't have any treatment for those, and except for symptomatic relief at the moment. And I think that's a major problem. We are working on non-invasive detection of affected fetuses, and that's work that Sean Ellard has developed very well, and we're using that in pregnancy when the pregnancy management differs according to the fetal status. But I think the actual treating it, The only thing which sounds a bit space age, but with the sulfonylurea patients, the sulfonylureas of affected mothers, it crosses the placenta. And the babies that have been born to those mothers, there are 2 of them, and both of them didn't have diabetes when they were first born. I haven't seen the follow-up on that, but maybe early treatment can be really helpful.
Good evening. I didn't notice that you were taking into account many environmental factors. I was wondering if there were plans to put that into your diagnostic tool, or I missed something.
I would like to, if I had something that was associated with a different cause. So it's not saying that environmental factors are not important. And it's whether, at the moment, if you take 2 identical twins that are genetically predisposed to diabetes in exactly the same way, there's actually work from King's College Hospital, and what that has shown is that on average about half of them, if one gets type 1 diabetes, the other one won't in 50% of the time. If you think about 2 identical twins, they are giving exactly the same obvious environment, but there is something that is different between one and the other. So I think we've got a lot to learn about the environment as well. And it's just because I'm a geneticist I'm talking about genetics, not because I don't think the environment is important. But actually, if you come to predicting type of diabetes, we haven't got something. You could put white Caucasian and it would make it more likely to be autoimmune type 1. So we will be able to put those things in, but that's not really, well, that could be environmental as well.
Say if one wanted to be a coal miner or something, would it be more obvious?
I haven't seen epidemiology that says that coal miner is associated with a specific type of diabetes. But you can't deny it because we don't know what the environmental cause that is critical for type 1 diabetes.
I think I might take an interest in these diagnostic tools anyway, but thank you.
Thank you.
Perhaps the last one.
Thank you for the talk. I'm from Saudi Arabia, and what I noticed that Saudi Arabia has 0 patients next to it on the map, while we have really high prevalence of diabetes. So what do you think are the main obstacles regarding this?
I think probably what's happened in PowerPoint, the thing has moved on, and actually it's 24. I know that we've got a lot in Saudi Arabia. There can be cultural obstacles, there can be other things, and I think what we are doing is by making this a service rather than something primarily for research, it's the doctors that come to us rather than us going to them. Things do change. There was a time in Saudi Arabia where they didn't come, and then suddenly what often happens is one patient is found to have it, comes off insulin, and then a lot will come after that. So the cause varies whether if you have more likely to marry your parents in those countries, there will be different causes than when it's less likely because it alters the genetics. But it is important. And I don't think some of the reasons that we've got less cases for France, for instance, is because the French had their own service. So I think you have to be careful because this is our referral things rather than the worldwide prevalence.
Go ahead. Would you like?
What's the proportion of patients that have type 1 diabetes that have another autoimmune condition?
That's a very good question, and it depends how long you follow them up for and those things. It's certainly hypothyroidism and celiac disease, they're often present. And what can happen is people can have 4, 5 autoimmune diseases as well as their type 1. And what we found is there can be genetic causes of being more likely to get autoimmunity apart from a general predisposition. We found some genes that actually in them of themselves make you likely to be autoimmunity without needing the general susceptibility.
Thanks very much. And I should say, Andrew, it was a pleasure. I think you're at a wonderful stage of being able to do genuine translation of knowledge from the lab into the clinic and back again. I think that the use of genetics in that way is wonderful. And I also think that your work and the work that you've described is perfect for the GlaxoSmithKline Prize, which is an international prize And you couldn't get more international than the last slide showing this particular thing. So thank you very much. All that remains is for me to give you these awards. First of all, the medal, and I guess then the scroll, and then the prize. And thank you very much indeed.
Thank you.